So today's e-seminar is going to be on plant-based diets and potassium management in CKD, and how do we manage and balance both of those. So we've got a great speaker today, Carla Avesani, and two panelists, Deborah, Clegg, Kieran Mccafferty. So my name's Smeeta Sinha. I'm a nephrologist from the north of England, and I'll be chairing the session. So I'll invite Carla Avesani first to introduce herself. Thank you, Carla.
Hello, good afternoon, good morning, or good evening, whatever you are in the globe. So I'm Carla Avesani. I am a renal dietitian by training, and currently I work as a senior researcher at Karolinska Institute in Sweden. Thank you very much for coming here.
Thank you, Carla. And our next panelist, or our first panelist, is Deborah Clegg. Deborah?
Hi, thank you so very much. I'm super excited about today's symposium. This is a topic that is a passion of mine. So my name is Debbie Clegg. I'm the Vice President of Research for a university in Texas, and I'm also a dietitian. So this is going to be fantastic to discuss the impact of potassium in the plant-based diet. So thank you so very much.
So we've had two dietitians, and just so that the medics amongst us don't feel left out, we have invited Dr. Kieran Mccafferty along, who's an academic nephrologist. Kieran.
Hi, I'm very much the least of the bunch, but my name's Kieran Mccafferty. I'm a kidney doctor by trade, working at Barts Health in London, and my main interest is clinical trials in proteinuria kidney disease and dialysis, along with potassium binders. It's great to see everybody, and I'm very interested in this. It's great session.
Yeah, Carla, we've got loads of people who are clearly rearing to hear your talk, so I'll hand over to you.
But so welcome everyone for today. And as Deborah said, this topic on plant-based diet and potassium management is in fact also a passion of mine, and something that rose a lot of interest in the last 2 years. And this will be the theme for today. Just a moment. Yes. So as a dietitian, when it comes to the dietary recommendations to patients with chronic kidney disease, sometimes I feel as in a puzzle when talking to patients, because we do need to combine different elements from the diet, like potassium, fiber, energy, probiotics, prebiotics, fat, protein, liquids, sodium. And all of this need to be combined to a diet that is adaptable for the patients regarding his or her food preferences, socioeconomic and cultural level. And after all, we need to combine all this information in a diet that is healthy, and it's also doable for the patient. And this is quite a challenge on an everyday basis. When it comes to potassium, I believe this is one of the most challenging elements to combine in a diet. So the dietary potassium recommendations to patients with CKD historically has been a diet where we need to restrict the potassium, the food sources of potassium from the diet. And the most important guidelines that we have for patients with chronic kidney disease, like the BPG, the CKD from Australia, they advise that if the patient has hyperkalemia, the potassium content of the diet should be restricted to about 2 to 3 millimole per liters per day. For patients who also have chronic kidney disease, salt substitutes containing potassium, like potassium chloride, should not be prescribed to these patients. And more recently, with the NKF-Kadoki clinical nutrition guidelines, we have a different recommendation, which I find very adequate, which it is, instead of having a threshold of potassium intake, we should adjust the potassium intake according to the clinical conditions of the patients to maintain normal kalemia. So I believe this is more adequate because it will bring to an individualization of the dietary prescription according to the clinical conditions of the patient, and also according to his or her food habits. When it comes to dietary sources of potassium, we do find a problem if we want to restrict the potassium intake, because the dietary sources are exactly those that we recommend as healthy food, like fruits, vegetables, nuts, whole grains, and beans. And all these components are exactly the components that make up the plant-based diet that we have been listing in different symposium and observational epidemiological studies to be protective to development of chronic kidney disease. But before going to this, I think it's interesting if we focus a little bit on what it is a plant-based diet. So plant-based diet is not a synonymous for a vegan diet. There are different types of plant-based diets like the vegetarian diet, the vegan diet, the DASH diet, Mediterranean, the Okinawan diet, and this health eating pattern diet. And the plant-based diet, after all, is a diet that will increase the servings of fruits, vegetables, legumes, oil seeds, and whole cereals, but with a decrease in the servings of animal protein, especially red meat. So it doesn't mean that animal protein is absent from the diet, but it just means that it's a small serving, a minimal serving per day. And depending on the type of plant-based diet, like the DASH and the Mediterranean, they also advise a high intake of olive oil. And in all diets, ultra-processed food and added sugar are absent from the diet. So after all, you can see that it's a quite healthy diet and not only a plant-based diet. What are the benefits that we find? So we do have many epidemiological studies nowadays showing that plant-based diet are protective for developing chronic kidney disease. I chose this one because I think it's a representative cohort of healthy individuals. So these are not individuals with chronic kidney disease. It's a cohort of about 15,000 individuals, and they had food frequency questionnaires of all these individuals, and they divided according to dietary pattern of plant-based diet. So there was one diet, one pattern, which is the overall plant-based diet, another pattern, which is the healthy plant-based diet, where foods that are plant-based but that are not healthy were negatively scored, the pro-vegetarian diet with only healthy plant-based, and the less healthy plant-based diet that also had products that were negatively scored because they were not healthy. And what did they find? The researchers found that when they divided these patterns according to adherence to these patterns in 5 quartiles, the individuals that were adhering more to in the 5th quartile, which was adhering more to the plant-based diet, the healthy plant-based diet, and the pro-vegetarian diet, they had a lower chance to develop chronic kidney disease as compared to the individuals that were in the 1st quartile of adherence to this diet. In addition, when they were evaluating the decline in the glomerular filtration rate, they observed that the individuals that were in the 5th quartile of adherence, meaning high adherence of the overall plant-based diet and of the healthy plant-based diet, they had a lower chance or a lower decrease in the eGFR as compared to the individuals that had a lower adherence to these 2 patterns of plant-based diet, showing here the benefits of this diet in developing chronic kidney disease. And why is that? Well, we can think first on a primary prevention for CKD. So a plant-based diet that has more foods containing potassium has a higher content of inorganic base acids, which decrease the all net of endogenous acid production, diminishing the endothelins, which are considered vasoconstrictors and will increase the hyperfiltration in the glomerulus, and therefore preserving more the glomerular filtration rate. So the lower the endothelins, the lower the hyperglomerular filtration, and the better the preservation of the glomerular filtration rate. When it comes to plant-based diet as a protective for metabolic derangements of chronic kidney disease, what we know is that these diets that, again, has high potassium content also have a higher proportion of basic amino acids because it's an alkali diet, which decreased the net endogenous acid production, contributing to ameliorate metabolic acidosis with 3 positive outcomes: decrease in bone reabsorption, improved insulin sensitivity, and a reduced sarcopenia because metabolic acidosis increased the degradation of amino acids in the muscle. In addition, this plant-based diet has higher content of fiber because it's exactly the foods that I mentioned to you that has more fiber. This will increase the growth of the saccharomyces bacteria in the intestinal microbiota, increasing the short-chain fatty acids, and this indirectly will contribute to a decrease in metabolic acidosis with a positive outcome in these 3 points that I just mentioned to you. So both for primary and secondary prevention, plant-based diets have been shown to be positive. And observational and also some other studies have shown, the interventional studies have shown that a dietary pattern that is contrary to a plant-based diet, meaning a diet with restriction in fruits, vegetables, nuts, beans, and whole grains, which has lower fiber content, has a higher risk for development of dysbiosis, intestinal constipation, an increase in the gut uremic toxins from the gut microbiota like pecresil, indoxil, and TMO, and a decrease in the acid load. This diet that has a lower content of fibers and fruits, vegetables, nuts, beans, and whole grains also has a lower content of vitamins and micronutrients, with a higher chance for oxidative stress, inflammation, and development of cardiovascular disease. And after all, this diet is an unhealthy diet that for the patient becomes a quite confusing message. How the foods that he or her learned during all his life, which is considered a healthy food, should be restricted from his life. So I think this becomes also a confusing message for the patient. So what we can look and what the scientific community, the nephrology community has started to argue in themselves is, what is the evidence that a dietary potassium restriction controls hyperkalemia? Or even, what is the evidence that higher potassium intake causes hyperkalemia? And the reason why these 2 questions are yet pending, it's because everyone does not feel comfortable to design a study giving a food rich in potassium for the patients with the fear to develop hyperkalemia. So the first studies that we have now are observational studies, and there are many. I chose 2 to show to you. So the first observational study that evaluated it, not the first one, but the first that I will show that showed that the dietary potassium was not associated with serum potassium, is this study that they evaluated 2 cohorts, one of non-dialysis CKD patients and another cohort of hemodialysis patients. So in both studies, they divided the patients that had normal kalemia from those with hyperkalemia. And you can see here that the potassium intake, the total potassium intake, and also the potassium intake adjusted for 1,000 calories was not different between the groups with normal and hyperkalemia in the non-dialysis cohort and also in the hemodialysis cohort. When the authors evaluated what were the main determinants of hyperkalemia, they observed that dietary potassium adjusted for 1,000 calories was not a determinant of hyperkalemia or even using potassium as a continuous variable, and higher serum bicarbonate was considered a protection for hyperkalemia. And the same result was also observed in the cohort of hemodialysis patients, where again, dietary potassium was not a determinant of hyperkalemia, but diabetes, serum creatinine, and serum bicarbonate were determinants of hyperkalemia. This is another observational studies in hemodialysis patients with a large cohort of 8,000 patients. And what they observed is that the serum potassium level was not adjusted with dietary potassium intake when the serum potassium level was considered a continuous variable, and this adjusted, the analysis adjusted and not adjusted, and also when they evaluated whether the dietary potassium intake was associated with 2 levels of hyperkalemia above 5.5 or above 6, again, the dietary potassium intake was not a determinant, showing again then, or confirming the previous study that dietary potassium in observational study was not associated with serum potassium hyperkalemia. And in this same study, they have also shown that dietary potassium intake was not associated with mortality, all-cause mortality, cardiovascular mortality, and non-cardiovascular mortality in this cohort of 8,000 patients on hemodialysis. And why is serum potassium not associated with potassium intake? Well, there are some confundatory factors that we should consider when we look in observational studies. First, the meal composition can modulate the serum potassium rise. So for example, fruits and vegetables, they are alkalinizing. So a diet that has higher content of fruits and vegetables, even if they have higher content of potassium intake, the alkalinizing itself will contribute to ameliorate metabolic acidosis and therefore diminish hyperkalemia or avoid hyperkalemia. In addition, potassium absorption is affected by intestinal transit time, and a diet with more fiber has a higher transit time and a lower absorption of potassium. And finally, a diet that has a higher glucose intake increase the insulin, and this will decrease the potassium rise in the cell in anemic patients. So all of these are confundatory effects that in an observational study, it's not possible to adjust. In addition, food diaries are quite imprecise to evaluate potassium intake because food diaries underestimate food intake. This is a well-known factor. In addition, the food composition tables, they are not precise and they vary in the potassium content from one food table to another. And finally, there are some conditions related with chronic kidney disease like the GFR, the presence of acidosis, the dialysis therapy, and others that even in models that this is adjusted, it's difficult to make this association or to show this association. And this is why I think it's important that we have interventional studies in randomized clinical trials to answer our question whether dietary potassium intake and hyperkalemia or increase in serum potassium are or not a condition that has a cause effect. Fortunately, we have one recent randomized clinical trial addressing whether the dietary potassium intake in patients with CKD3 can lead to hyperkalemia and improve in the blood pressure. So this is a study that included patients with normal kalemia in CKD stage 3, so quite well-preserved renal function. And this was a crossover design, randomized study with 4 weeks in each diet. And there were 2 diets, a high potassium diet, a low potassium diet, and both diets had low sodium content. And this was a well-controlled study because the participants, they got the meals from the hospital and they were eating the main meals that came from the hospital. So it was quite controlled, well controlled for 4 weeks in each diet. And what did they find? Well, the first outcome was amelioration in systolic and diastolic blood pressure. So they did not find that depending on the type of diet, the blood pressure ameliorated after the 4 weeks of diet. There was a tendency to a higher decrease in the systolic blood pressure, but when they evaluated the P4 interaction, this was not significant. As for the changes in serum potassium, what we find is that first, the urine potassium increased after the higher potassium diet, more than after the lower potassium diet. And this is because, of course, they were eating more potassium. So this is a measure of adherence to both diets. Second, the serum potassium after the low potassium diet decreased, but after the high potassium diet increased, and this was significant under the point of the P interaction. Although the median values here are showing that patients were normokalemic, we should not ignore that there was an increase, and these are patients with preserved renal function. In addition, when they evaluated the prevalence of hyperkalemia in the 4 weeks in both diets, you can see that the prevalence of hyperkalemia with the diet that had higher potassium intake was higher when compared to the low potassium diet, and this was about 7 to 10% of the patients developed hyperkalemia. So I believe that although 90% did not develop hyperkalemia, we should not leave unattended the 10% that develop hyperkalemia. So we need to be very careful, I believe. And so I think we should have caution with high potassium diets, but this does not mean that we have to restrict all healthy potassium-rich foods. And I'll talk to you later on about this. And at all moments, we should monitor serum potassium levels when we are talking to patients about a healthy plant-based diet. So it's not just prescribing and seeing the patient once a year. On the contrary, we need a close monitoring together with the nephrologist. This is also a very new study that was published some weeks ago that evaluated the effect of a short-term potassium chloride supplementation in patients with CKD. So these patients were supplemented with potassium chloride for 2 weeks. And what they have shown is that the urine potassium increased after 2 weeks. The serum potassium also increased after 2 weeks, and these are patients with CKD stage 3. And 11% of these patients developed hyperkalemia. There was no changes in blood pressure during this short term of supplementation with potassium chloride. So again, although 90% or 89% of the patients did not develop hyperkalemia with the supplementation of potassium chloride, 11% did, and these patients should be looked carefully. So in my opinion, I still think that we should be very cautious with the use of potassium chloride. I would not recommend, because also we don't know what would be the effects on long-term use. We don't know what would be the effects in individuals with lower estimated glomerular filtration rate and mainly on dialysis. But there is one missing link here that also we should comment about, which are the ultra-processed food or only the processed food in general. So all this processed food and ultra-processed food like bread, the chips, processed meats, unprocessed meats, wine, processed juices, and the sodium-reduced products that replace the sodium from the salt to potassium chloride, they should be looking carefully. So these potassium additives that are within all this processed food, they are used as stabilizers to preserve the food for a long shelf time. It alters textures, improve flavor, and it's really used for the food industry. And it has been shown that the potassium bioavailability of food additives is almost 100%. But for fruits and vegetables, it's from 50 to 6%, meaning that the absorption that we have of potassium when it comes from organic food, like fruits, vegetables, and so on, is much lower than when we eat a processed food that has potassium additives. So I believe it's time that we start teaching our patients to read the labels. And the food industry is not obligated to show in the label that they are using potassium chloride. Some or any other type of additives that you can see here are all very complicated names, and there are 14 potassium additives used by the food industry currently. So what we can do, although difficult, but I believe we can make handouts and teach patients is to read the food labels, looking for all these E that are, that means that these are potassium additives. And these are examples from Sweden it's in Swedish. I will not make you suffer reading it, but I'll just ask you to believe, like kalium phosphate. So these are examples that I find on the label of products that are using potassium additives in processed food or ultra-processed food. So they are really present. And if you see here, I know again, it's all in Swedish, but they don't have potassium content. So in fact, we need to teach patients to read the label. And this is a very interesting study that I recommend you to read from Pickard et al. From Canada, where she made 2 menus, one containing processed food with potassium and another menu containing processed food without potassium additives. And you can see that the menu that had potassium additives had almost twice as much as the menu with processed food not containing potassium additives. The difference was almost 2,000 milligrams of potassium per day, that if we convert this in banana currency, which is the most well-known source of potassium that we know, would be equivalent of eating 4 bananas a day. So please, let's start to look to the processed food and the potassium additives. I believe we do have some future perspectives as well on how to control the potassium intake for patients with hyperkalemia and allow them to have a more plant-based diet. And this is the use of some potassium binders. So currently in Stockholm, we do have one ongoing study, hopefully finishing in December of this year. This study is sponsored by AstraZeneca, so I'm showing this to you. The conflict of interest is the helpful study. So in this study, we are including patients with CKD stage 4 and 5, not on dialysis, and with hyperkalemia. These patients, in the first 3 weeks, they are asked to follow a low potassium diet and a low protein diet, and the sodium zirconium cyclosilicate is used to normalize potassium in the first 3 weeks. In the 3rd week, the patient has a normal potassium value, normal kalemia, and he starts with a high potassium diet, keeping the low protein intake. And in order to increase the potassium intake, we send to the patient's house a food basket containing 3 servings of fruits, 2 servings of vegetables, 2 servings of whole cereals, 2 small servings of white meat or eggs, 2 servings of nuts, and yes, that's it. So the patient receives in his house this food basket once a week for himself, herself, and for every adult living in the house. This is an individualized food basket, so the patient will fill in all his or her food preferences, and we buy the food basket considering the food preferences. And this diet continues for another 3 weeks with the concomitant use of sodium zirconium cyclosilicate. And I will show you some preliminary findings from 17 patients. So what we find in terms of changing in the diet, in the food intake, is that the intake of servings of vegetables per day increased, first maintain after 2 weeks, and then after the intervention with the food basket increased after 6 weeks. The intakes of servings of fruits also increase comparing to the baseline to after 6 weeks. The same occurs for the intake of servings of nuts, and this is per week, not per day. The intake of dairy products increased significantly, and we believe it's because we asked them to decrease the protein intake, and perhaps they were more fixed in decreasing the sources of white meat, and consequently they increased the dairy intake. The fiber intake increased significantly, and the protein intake also increased because of the dairy intake. When it came to the potassium content, we saw that the urinary potassium decreased after 3 weeks because we asked them to reduce the potassium intake, but increased right after. The potassium intake was also noticed as a significant increase. The plasma potassium decreased and kept in normal levels even after 6 weeks. However, when we finished the follow-up in week 6, we still had 3 patients with hyperkalemia, being hyperkalemia from 5.1 to 5.3, so not really a high level of hyperkalemia. The amount of sodium zirconocyclosilocate needed to maintain normal kalemia, I am sorry, the red circle should be in here. So it was, oh no, it's in here, it's correct. So 94% of the patients needed 10 grams of sodium zirconocyclosilocate to keep these levels of normal kalemia, and the ACE and RIBs inhibitors were not needed to change during the study, which is a positive effect since in the presence of hyperkalemia, sometimes the nephrologist changes or decreases this antihypertensives that are protective for the kidney of patients with chronic kidney disease. So I believe that although this is a feasibility study, we still have here some results that can indicate to us an approach for the future with confirmation of other studies. So after all, how to combine a potassium restriction and a plant-based diet if this is needed? So the first thing that I would say is that we should not restrict healthy foods before giving a careful thought, considering the serum potassium, the glomerular filtration rate, the current potassium intake, because unfortunately, we still see some nephrologists and even dietitians that when the patient has chronic kidney disease, regardless of the serum potassium, potassium restriction is already counseled. So please first evaluate, give a careful thought, individualize your approach. But if you find that potassium restriction is needed, then I believe that the correct approach is replace fruits and vegetables with high potassium content for those with low potassium content. And for that, there are lists of fruits and vegetables that have high potassium and those with low potassium. This list should be individualized according to the country you live, because this is very seasonable. So it's interesting that you look in your country. We can also, another approach that is efficient is to cook vegetables and legumes and beans in water to decrease the potassium content. So these are some steps. First, you have to counsel the patient to unpeel the vegetable and chop in small pieces so the surface with water will increase. Then it should be cooked until it should be boiled in water until it's cooked. The water will be drained and you wash it with cold water. So this procedure eliminates about 60% of the potassium content, and the same can be done, the same procedure can be done with beans. So connecting the dots, if a healthy diet low in sodium and potassium CKD patients, how to combine both. I would say first, avoid ultra-processed food because they contain these potassium additives, and also avoid the salts containing potassium, like the potassium chloride. Second, do not restrict healthy foods before giving a careful thought, considering serum potassium, the glomerular filtration rate, and the current potassium intake, because some patients have hyperkalemia and the potassium intake is not high. Third, if dietary potassium restriction is needed, replace instead of restricting, replace fruits and vegetables with high potassium content for those with low potassium content. Replace sodium chloride for herbs to add taste instead of counseling them to use potassium chloride. Cook vegetables, legumes, and beans in water with the procedure I showed to you. And prioritize a healthy diet considering dietary habits, cultural and socioeconomic condition. And I chose a banana to connect the dots a little, because as you know, banana is always the symbol for potassium-rich food. I am a vice chair from the European Renal Nutrition Group from ERIA, And together with Alice Sabatino, Juan Cajero, and the whole team, and also Kristen Mayas from Spain, we developed these handouts with instructions that are in a language friendly for the patients about the dietary content of potassium in foods, the procedure that I just showed to you to cook vegetable legumes and beans, foods with low potassium, low sodium content, and phosphorus. And these are available in the website and in different languages, in English, French, Italian, Portuguese, and Spanish. This is free to download to distribute in your clinic with your patients. So please feel free to use those. And finishing, I'd like to thank the group that I work with. So the researchers at Baxter Novum and at Renal Medicine from Karolinska Institute, especially the professors Bent Lindholm and Peter Steinwinkel, and also the kidney research unit at Karolinska University Hospitals with the research nurses that make all the magic happen when it comes to collecting data. Thank you very much.
Thank you so much, Carla. It's astonishing to me that we're talking high potassium in CKD populations. I think if you'd have told people 15, 20 years ago that this would be seriously being considered, they probably would have looked at you a bit funny. So yeah, and I saw that a lot of the papers that you presented are recent, so I expect this is an area of great interest and the evidence is going to continue to emerge over the next few years. So I'm going to start with the questions because we have an awful lot. I'm going to start with the plant-based diets because that's something else. Patients are actually coming to us and saying, I want to follow a plant-based diet, or which one should I have that manages my kidney disease? So trying to balance protein, potassium, and flavor. I mean, yeah, what are your thoughts? And I'm also going to ask Deborah this one before Kieran, because I think the dietitians probably get this question more than we do.
No, and I just want to thank Carla for an outstanding presentation. That was truly fantastic and really brings us up to date with what sort of the state of the nation with respect to where potassium is. And so with respect to plant-based diets, I love Carla's approach, which is individualize them, right? Let's first figure out what types of foods the patient wants to eat, and let's work with them together to figure out how we can incorporate those types of foods into a diet. I was recently referred a patient from Dr. George Baccaris. Some of you may know who he is, and this patient was told to go follow a plant-based diet. They had never eaten a plant-based diet. They were completely destroyed. They had depression. They had lost a large amount of weight because they didn't know what to eat, and it was horrific. And so I think it goes back to, again, to what Carla was saying. Let's first interview those individuals, find out what are the types of foods you'd like to incorporate. Do you want to have more of the beans and nuts? Do you want to worry about having balancing your proteins with respect to your fruits and vegetables and beans? Or are you more looking at just reducing the amount of meat that you're actually eating? So I would advocate for a highly individualized approach.
Thanks, Deborah. And I presume, Carla, you're obviously going to agree with yourself.
Yeah, I will absolutely agree with Deborah. I have no further to complement.
Great, thank you. So we've got a few more questions, and I'm going to ask Kieran to comment on the plant-based diets. And do you get those questions? And how confident are you in responding the way Carla and Deborah have? And I guess, what would you say to your patients?
So obviously, being only a mere kidney doctor, I, very much cede to my dietetic colleagues' advice. But I think certainly I've gone from we must control potassium at all costs to really look at what are the dangers of overly controlling potassium. And I think it's really important, particularly in dialysis, that patients' quality of life is one of the most important things, because ultimately we can't make a huge difference to people's outcomes on dialysis other than transplantation. So I think we should be really focusing on quality of life, and that's where overly restricted diets totally destroys people's quality of life, and the understanding of the link between really trying to get a too restricted diet and malnutrition. And so really it's taken a huge weight off my shoulders that I was always so focused on potassium, and actually now, knowing that the relationship between dietary potassium and serum potassium is not that good, that actually allowing people, giving people permission to maybe eat things that are more culturally congruous with, East London, there's a large amount of ethnic minority populations, to allow them to eat more with their family, which revolutionizes the quality of life. And it makes me feel really guilty that for years I was like, you mustn't do this, you mustn't do that, overly restricted, trying to get this potassium down. And actually, we know that it doesn't make a huge amount of difference. And so it's been fantastic. I guess the only other thing I'd say is that, particularly in these times, it can be more expensive, and highly processed food is unfortunately very, very cheap, and poverty and hyperkalemia probably go together. And so there's a kind of more of a social policy that we need to get, healthy, fresh fruit and vegetables can be more expensive than highly processed meats. And so that can be a challenge to some of my patients.
Yeah,
I'd like to add, Kieran, that I also think that for patients mainly on hemodialysis, but also on peritoneal dialysis, we see more the patients because they are in the clinic. So I think it's very important to do the monitoring over time, but as they have monthly exams of potassium, so we can really individualize as long as we have dietitians and nutritionists that can talk to the patient, because this is other thing. Making an individualized approach takes time. We need dietitians and nutritionists that train dietitians and nutritionists that can do this with the patient.
Yeah, and that's not universally available everywhere, is it? And it does bring in a question that we've got here around, if we're going to embrace relaxing potassium, in some of your presentations, you did show that a higher potassium diet can lift up the hyperkalemia risk, albeit in a smaller cohort. If we allow people to have a more liberal potassium diet, how often should we be monitoring them? Would you increase the monitoring frequency? And how feasible is that? And should we be doing it fasting? Should it be postprandial? When do we do it? I'll give that to Deborah to start with.
No, I saw those questions in the chat or the comments and questions, and I thought they were spot on, right? So several parts of that question. So first of all, I agree that knowing when the potassium is elevated relative to the food intake is really important. And people, even in the chat, were talking about the circadian rhythm, and there's an incredible circadian rhythm with respect to potassium. And so I think it would be important to, especially if you had an individual who all of a sudden popped up with an elevated level of potassium, I think that's the individual that you'd want to say, okay, when did you eat relative to this blood draw? Are you you'd open up a dialogue about that and then recheck. But there's another really important point that I think was sort of alluded to within the overall chat, which was, how high does potassium go after you've eaten a high potassium diet, right? And so what we're now doing is we're looking at, someone comes in for their usual blood draws and for dialysis, but we don't again know when they ate relative to that draw. And the patient that I think is the most concerning, and I think that Carla alluded to this, is the patient who still has hyperkalemia, even though they're eating this diet. That's the person I would love to say, okay, eat a high potassium diet. Now, 2-4 hours later, let's recheck your potassium. I don't want them to all of a sudden pop up to a 6, but then when we check them later, they're already down to a 5. It's those excursions in potassium that I think that we have to be so incredibly careful with. So I think that more testing might give us more information about how liberal we can actually be. So I'll let my colleagues address that as well.
Carla, any comments from you around that?
In addition to everything that Deborah said, that I agree, I believe that the higher risk are those with hyperkalemia and low renal function, not yet on dialysis. So for these patients, I would be extra careful because we don't know what is the postprandial serum levels. So this is a study that we intend to start in Sweden soon, hopefully next year, to evaluate what happens when they eat a high potassium meal for normal kalemic patients after 3 hours. So to see how this raise occurs and what is the difference between the food sources that we have, if it is organic food or if it is processed food. But I believe that this group of patients that are prone to hyperkalemia and are not yet on dialysis, these are the ones that we should be careful and evaluate serum potassium very often.
Okay. There's a really interesting question that I hadn't even considered asking. Might be a quick response from our dietitians. Maybe Kieran knows. But is potassium influenced by the circadian clock?
Yes.
Okay. Yeah. Wow. I did not know that. So what impact does that have on your management?
No, I think that it's incredibly important, especially if you happen to have a shift worker, right? Or somebody who is working off hours and you're testing the potassium. I think that it actually does influence it. And I would also think very carefully about when you're drawing that potassium relative to that normal circadian rhythm for that individual. And there was another point that Carla brought up that, the bioavailability. I was going to also say not only the bioavailability of the foods that people are eating, but also whether they're constipated or not, right? So
true.
what we haven't really addressed is, okay, so you've eaten this diet, but all of a sudden you're really constipated. Is that contributing to your overall elevated level of serum potassium? It goes back to the importance of eating the fresh fruits and vegetables, but I think that there needs to be another part of the discussion, which is the relative gut motility.
And I was just going to make the point that I was going to be a bit of a nihilist here and maybe a bit of a doubting Thomas, but I was going to say that all the data around, and the change in potassium post-meal is all really interesting. And it's great that Carla's doing the study because that's going to answer the question. But when we think about hyperkalemia, we think back to the kind of classic diagrams of the U-shaped curve with the high potassium associated mortality and the low potassium associated mortality. Now, those big studies weren't monitored for whether you eat, how long after you eat. It was just a random potassium. And so actually interpreting, if the potassium goes up, is that the potassium associated with increased death or not? We don't know. And so we can almost ignorance is bliss in the sense that the studies that we rely on to inform us what is hyperkalemia, the definition of hyperkalemia and the risk, were all done in kind of dirty data that was randomly checked. So I think inferring anything from our postprandial potassium, without the data that Carla's going to generate, I don't think we need to worry as much about, because we don't know what we don't know.
Yeah, absolutely. I mean, we also have new tools, don't we, for management of hyperkalemia? Should, we've got our potassium binders. As medics, we're quick to reach for the pills. What do people think about relaxing potassium in the diet and using binders, or is that a no-no? I'm going to give that to Kieran first, because I know that he's.
I mean, Carla's done the study, and there's other studies, around, and I think that is probably the most important thing that we can do, because relaxing people's diets can improve their quality of life, can make them happier, and can maybe reduce their, cardiovascular disease. So I think that is clearly the most important thing that we can do. How can we make our patients happier and healthier? And so, using potassium binders to offset any small risk of hyperkalemia with an increased diet would definitely be a useful thing. For example, particularly people who aren't having dialysis. So Carla mentioned that the high risk group is those people who are advanced CKD but aren't quite on dialysis yet. So, for example, those people who perhaps have chosen not to have dialysis, and using potassium binders to allow them to eat more what they wanted in their final illness, I think is a complete no-brainer from my point of view. But obviously, we still need to see the impacts of using potassium binders to control people's potassiums, to then show that their survival is different. And obviously, AZ are doing a study, Dialyze, looking at a big phase 3 study in controlling people's potassium levels with Lokelma, and looking at cardiovascular outcomes. And so we need that data to close the loop of the importance of potassium binders for our patients.
So Carla and Deborah, are you doing that? Are you, in clinical practice, what are you actually saying to your patients when they do come in with hyperkalemia and you see that their diet's a little bit off, but you like the diet, it's a healthy diet? What do you actually do?
I would just, I cannot answer this now, because in Sweden, I'm not yet a registered dietitian, hopefully in the next 2 years, because it's a quite long process. So I will leave this to Deborah, but I think we should be careful. And one point important about potassium binders is that, at least in our study, we just evaluate fasting potassium levels. And I think one point that we missed was to evaluate postprandial. So let's not forget that we, even with this potassium lowering medication, which not always it is a potassium binder like the sodium zirconocyclosilicate, we have to be careful with the postprandial.
No, and I love that because I think those are the data that we're missing, right? So tolerance is phenomenal with the potassium binders, but what we're missing is it covering those episodic elevations in potassium that may be related to food. I've also heard from some physicians in the United States that where they're super excited about the potassium binders, they're also worried about giving them to patients because they think the patients are going to go crazy. And on the banana meter, they're going to eat 25 bananas and they're going to think that they're covered. I think that comes down to some education and some trust, right? I mean, so we're really trying to, I love the fact that Kieran is reminding us that it's quality of life, right? And so if they can help someone have a quality of life that they were not able to achieve prior to the binders, that we're doing such a benefit to the patient. But I think I'm a data monger, so I'm really looking forward to seeing much more data about the efficacy of the binders with respect to the actual high potassium diet. I was super excited by the data that Carla actually demonstrated for us.
And just one curiosity, we had one patient that was consuming a lot of potato chips. And this patient was consuming the sodium reduced potato chips because this patient thought, well, at least it's better. And he was consuming plant-based diet, but with sodium reduced products that probably had the potassium additives in addition to the potassium chloride. So sometimes, as I said, it's not only the bananas, it's also the ultra-processed food that we have to be careful.
So some of the questions are focusing on, which plant-based diet, with a particular concern around metabolic acidosis, but also impact on protein. So if you had to pick a plant-based diet, two questions. If you had to pick a plant-based diet for your renal patients, which one would you go for? Because you had quite a few at the beginning, or would you not recommend that because of the protein side of things? And I'll give that to Deborah to start with. And then
I'll take it first, and then I'm gonna ask Carla as well. I'm a huge fan of the DASH. I love food in their natural form, and I love a moderate amount of animal protein. I just think that it's easier to get complementary proteins by eating an animal-based diet, having a small amount of the animal proteins. I also love the data with respect to the blood pressure improvement with the DASH diet, and I love the overall improvement in acid-base balance. So I think that there are multiple winners. I think it's also, I guess, because it's more the diet that I follow, I find it to be easier than some of the other ones, but that could also be I admit it could be a personal preference as well. So Carla, I don't know if you have any other thoughts.
I think it would be the one that it's more culturally acceptable. For example, the DASH diet in USA, I believe that would be easier, but the Mediterranean diet in USA would probably not be so applicable. So, and the Okinawan diet, we do have in Sweden, not in Sweden, but in the Nordic countries, what they call the Nordic diet with more salmon and so on. So I believe we have to play a little bit with the cultural possibilities, because after all, let's face it, a plant-based diet, in simple words, is more servings of fruits, vegetables, nuts, whole cereals, and reduced servings of animal protein sources. But I would choose the Mediterranean because it has wine, of course.
Very good. I suspect Dr. Mccafferty might do the same too. Okay, I've got some quick fire questions for the last 3 minutes that are practical things. So if you boil vegetables and legumes, apart from tasting pretty grim, do you lose vitamins and minerals, and how long should you be boiling it for? So who wants to take that one? Quick fire.
Yeah, you're losing vitamins and minerals. Yeah, definitely are. And I think that the answer is you want to boil it for the least amount of time, but still get the maximum amount of benefit with respect to reducing the potassium content. So, you don't want them to be total mush. Some structure left to the item that has been boiled, I think would be outstanding. But the key is getting rid of the water and doing it in rapid form so that the item doesn't reabsorb all the potassium-rich water that you've now just tried to get rid of.
Okay, super. Another one, and maybe Carla will know this. It's from Chile. So lots of seafood, which contains a lot of potassium and sodium, similar to a Nordic diet. What do you do for those? How do you get rid of potassium in fish?
I think I will not know how to answer this, but I saw one study many years ago, by many years, I mean 10 years ago, I need to read this again, that showed that by cooking chicken, like poultry, the potassium content reduced. I don't know if they tested this with fish and seafood. So I will not be able to answer this for sure.
I'll jump in really quickly. If the item can drain, you're going to lose some of the potassium. So if you put it on a grill, it has the ability to drain. Anything that has the ability to reabsorb whatever it's been cooked in, if you fry it or whatever, it will have a higher amount. So if you can grill that fish, broil it, but not have the juices touch it again.
Super, that's helpful. Kieran, should we accept a potassium of 5 now for CKD 3 to 4?
I think it's a really interesting concept. So what I would say is that again, going back to the big epidemiological studies of, looking at potassium and mortality, there is an inflection above 5. And so I think, particularly in dialysis, we've kind of accepted hyperkalemia because we couldn't really do anything about it, because if we tried to make it normal, we would make our patients miserable by making them do too long dialysis, too frequent dialysis, or not eat any food. And so I think that the era of potassium measures has kind of remove the chains of being able to control potassium more easily and more palatably. And so I think now is probably the time to rethink again about actually aiming for true normal kalemia. I know that in nephrology there's a bravado about, oh, I don't worry about potassium unless it's more than 5.5 or 6 or 6.5. And I think we need to get away from that fact and look back to the evidence, say, where does the evidence suggest is the lowest mortality? And if we can get that patients to that while maintaining their quality of life, while maintaining their sociocultural enjoyment of food, while maintaining their ability to take potassium binders, then I think we should do it.
Okay, gosh, thank you so much to our panelists and Carla for doing that fantastic presentation. I think what we can all say is that things have changed and things are going to continue changing, but individualization is key. And I think we could probably stop there because we now have individual diet plans, individual drugs. So talk to the patients, make sure you have dietitians that are trained and in your service, and yeah, speak to your patients, listen to them, and individualize care.